And now we're going to go talk about rheumatology. I'm going to leave this slide up, but you have this more or less in the notes. Okay? So it's going to be in your notes, but I'll leave that up for you. A 7-year-old girl has been complaining of pain and swelling of the left wrist and right knee off and on for the past 3 months. She has been previously healthy. The pain is worse in the morning and improves throughout the day. Physical exam is remarkable for swelling and effusion of the right knee with decreased range of motion. This question has tons of information in a couple of sentences, okay? So first of all, it talked about the left wrist and the right knee. So that's significant, right? 2 big joints, right? 3 months. So the duration is important. Worse in the morning, gets better as the day goes on. Okay? And she has effusions. So that's chock full of information there. Okay, juvenile rheumatoid arthritis. Chronic, this has been 3 months, chronic non-suppurative inflammation of the synovium and joints. Joint effusions, destruction of joint cartilage, bone deformities, fusion of the joints and of the bones. Okay, those are things that you're going to see with JRA. There's no specific etiology. There are some triggers. For example, we talked about Lyme disease, right? And Lyme disease, 3rd stage, arthritis. So there could be there are some infectious causes for arthritis. Sometimes there are environmental triggers, but we really don't have one particular cause. Morning stiffness gets better as the day goes along. That's important. Okay? Joint pain and joint swelling. Those are things that you're going to look for when you're reading the question. Okay? And there's decreased range of motion. Now, it's going to be subclassified. There are 3 major categories of JRA. I'll mention it according to your notes. Polyarticular. Polyarticular implies many small joints. Okay? I'll get to that. Many small joints. Pauciarticular implies fewer number of joints, but big joints. That's, in this particular girl's, the wrist, the knee. And then the third form, major form, is what we call systemic. And with systemic, they generally will have fever and rash, and they can have this for some time before the actual joint manifestations start. Okay? So polyarticular, many small joints, usually the hands, and that can be subdivided into R rheumatoid factor positive, which is usually older age of onset. Think of nodules. Think of females. There's also the ANA positive, also females, but younger onset. And then there's the seronegative, where they don't test positive for those things. The pauciarticular, fewer joints, bigger joints. And it can be, it's not necessarily a symmetrical distribution. So it can be the right knee, the left wrist, things like that. And that's subdivided into ANA positive, which is the most common form of juvenile rheumatoid arthritis. And this is going to be more common in girls, and there's a higher risk for eye involvement, and that means iridocyclitis. There's the rheumatoid factor positive pauciarticular, and there's the HLA-B27 positive pauciarticular, which is more common in boys, and they're at higher risk for ankylosing spondylitis. And then there's the ones that are pauciarticular and don't test positive, seronegative. And then the systemic, and this is where they might fool you by throwing in a JRA question, and it'll be the child with the fever of unknown origin. They've been having fever off and on for a long time, sometimes a few months. So with JRA, they will have fever, they can have a rash. And this is what they call a macular salmon-colored rash. It usually appears with the fever. So it comes and goes with the fever. And then after a certain amount of time of having these fevers that no one can explain, the patient then starts to have joint involvement, joint manifestations. Okay? Systemic JRA can also have hepatosplenomegaly, pleuritis, and pericarditis. There is no one diagnostic test for JRA. Okay? It's usually clinical diagnosis. So look for onset less than 16 years of age, arthritis of two or more of the following: limited range of motion, tenderness or pain on motion, increased heat in one or more joints. So it doesn't have to necessarily be an arthritis, but you can have these symptoms too. 6 weeks or more duration. And then the onset type in the first 6 months will be polyarthritis, 5 or more joints, to call it polyarthritis. If not, it's called oligoarthritic. And systemic will be arthritis with the fever. Okay? And this is a diagnosis of exclusion. You have to rule out other things before you say, it's arthritis. Okay? SED rate. Is it helpful? Maybe. It's not diagnostic. C-reactive protein, usually elevated during the acute phases, the exacerbations. Otherwise, the SED rate comes back down when you're feeling good. And this is characteristic of arthritis. You have good days and bad days, or you have good weeks and bad weeks. And look for the morning stiffness. Okay? You can have anemia of chronic disease. You can have leukocytosis and thrombocytosis. X-rays will show soft tissue swelling. Later on, you can actually see bone and joint changes. But there is no one specific test. Here's a little nodule right there. The other thing that you can see in this patient with JRA is probably this joint is affected and you have a little bit of atrophy of the muscle here. Okay? Because it hurts, so if you don't use it, you'll lose it. So the muscle atrophies because it hurts, so you're not going to move that thumb, and so you get some atrophy of the muscle. This particular patient has effusion of the knee. So it's going to be characterized by joint pain, swelling, and effusions. The treatment goal is going to be preserve joint function and try to have a normal life, which is very hard to do if you're hurting and you can't move well. Okay, and you're 8 years old, 10 years old, and it's happening. Okay? Non-steroidals are the first course. You can use aspirin. Usually most people will use non-steroidals like ibuprofen or naproxen. Then you step up to methotrexate or antimalarials. Steroids have very few indications in JRA. They're very good for lupus. Physical therapy is very important because you want to maintain joint function. So, like I said, if it hurts, you may not want to walk or stuff, so you need to have physical therapy or else you get atrophy of the muscles. What else should you think about with juvenile rheumatoid arthritis? Rheumatic fever, because that can cause arthritis and fevers and swelling. Lupus, ankylosing spondylitis, osteo, but usually that's going to be one joint. Lyme disease, and leukemia. That's the second time I mentioned leukemia and joint problems or bone problems. Okay? All right, the next patient. A 10-year-old girl presents with fever, fatigue, and joint pains. Physical exam is remarkable for a rash on the cheeks, swelling of the right knee, and a pericardial friction rub. She's anemic, has elevated blood urea nitrogen, and an elevated creatinine. Okay? I could change this to a 9-year-old girl presents with a 2-month history of malaise and anorexia. Father's been taking her everywhere. No diagnosis. She shows up now with a hemoglobin of 5, tachycardic, hypotensive, has decreased breath sounds, and has a rash, a hypopigmented rash, spread several places on the skin. She is of Haitian origin. She has a chest x-ray that shows a large pleural effusion. CBC shows anemia, hemoglobin of 5, and BUN and creatinine are elevated. So what's your differential diagnosis? So lupus, because we're talking about lupus, sure. What else? TB, very good. What else? Pardon? Rheumatoid arthritis. Sarcoid, okay. Malignancy? How about malignancy? Sure. Wilms? Nah, she's 9 years old. Yeah, some kind of malignancy. How about HIV? Oh, yeah. Oh, yeah. Okay. So lupus, actually this girl did have lupus. They did it. She was intubated because of her hemodynamic instability. She received some dopamine. She received some blood. She had blood work done before her blood was taken. She had a tap of this large pleural effusion. There was acid-fast negative, no malignant cells. Okay? And her ANA came back positive, double strand. So she has lupus. HIV was negative. Right? PPD was negative. So lupus can mimic a lot of other diseases. It's an autoimmune inflammatory disease. Multiple organ systems are affected. And we don't know the etiology. It's probably multifactorial. And you have autoantibodies, particularly against DNA and other nuclear antigens. Sunlight can exacerbate it. Remember, it can also be caused by medications, such as anticonvulsants or sulfa drugs or antiarrhythmics. That is a reversible lupus. Okay? The medication ones are basically reversible. And onset is usually after 8 years of age, and it's much higher in females. Okay? Again, it can mimic many diseases. So the differential diagnosis is pretty broad. They can present with fever, malaise, arthritis, arthralgia. So you may be thinking of JRA or rheumatoid diseases. And they can have skin manifestations. This is the butterfly, malar butterfly rash, exacerbated by the skin, the sun. So there's a sun photosensitivity. They can have pleural or pericardial rubs. They can have a vasculitic rash. That's what this particular girl had. They can have serositis. They can have GI manifestations from the vasculitis. Remember Liebman-Sachs endocarditis and lupus. They can have heart failure. And the majority of children will have renal involvement. They can also have CNS involvement with seizure, stroke, and aseptic meningitis. And they can have a vasculitis similar to a Raynaud's phenomenon with the, blanching, the redness, the blue, the cyanosis. And the mnemonic for a lot of these things with lupus is M.D. Sopenhair. You have it right there. So it's a malar rash, a discoid rash, that's a completely different kind of rash, serositis, oral ulcers, arthritis, photosensitivity, neurologic signs or CNS like seizures and strokes, hematologic findings, anemia, leukopenia, thrombocytopenia, anti-nuclear antibody, immunologic, and renal. So that's a nice mnemonic to remember lupus. The best screening test. So your best initial test is going to be your ANA. Okay? The best test is your double-stranded antibodies to double-stranded DNA, but that's only going to be positive during active disease. Okay? So you have to differentiate the two of them. The best screening test is an ANA. C3, C4, and CH50 will be decreased during active disease. Okay. Anti-Smith antibodies are found only in patients with SLE, and nephritis is confirmed by biopsy. But what do you need to do first is an ANA when you have all those symptoms, an ANA. And then you follow up with your double-stranded during active disease. Okay, non-steroidal drugs can be used, but remember that they can be nephrotoxic. Patients who have thrombosis and patients with antiphospholipid antibodies need to go on anticoagulants. And steroids, as opposed to JRA, where steroids don't help, there's few indications. Steroids are like the bread and butter of treating lupus. 5-year survival is now greater than 90%. Children usually die because of renal complications or CNS complications or infections. Now there's a subset of lupus, neonatal lupus, and just associate that with congenital heart block. That should be like a knee-jerk response. Okay, so they get a transfer of antibodies, and manifestations generally resolve, except they end up with a congenital heart block. Okay, let's fix this. An 18-month-old has had fever for 10 days. He now has conjunctival injection, a very red tongue, and cracked lips, edema of the hands, and a truncal rash. Kawasaki's disease, or mucocutaneous lymph node syndrome, is a diagnosis of exclusion. There are certain criteria that you have to fill, and you have to eliminate other diseases. Okay? And it's also not known what causes this. Maybe an infectious agent, probably a viral infectious agent. Okay? Patients will be less than 5 years of age, so know your age ranges. And you have here your criteria for diagnosis. Okay? You have to have fever. Fever for 5 days or more. And then you have changes on the periphery. You need to have 4 of the next 5 criteria. 1, 2, 3, 4, 5. You have to have 4 of 5 of these. So fever for 5 days or more, and then changes of the peripheral extremities, which is a kind of an indurated rash or indurated edema. In the convalescent stage, that's when you can have the peeling of the skin, usually in a glove distribution from the nails back to the wrist. I'll show you pictures in a minute. A rash, so there's an indurative edema, a rash, bilateral conjunctival injection. Okay? It is going to be a non-purulent conjunctival injection. And then changes of lips and oral cavity, that's their strawberry tongue, your cracked lips. And the least constant, even though it's called mucocutaneous lymph node syndrome, the least common is going to be an acute cervical lymphadenopathy, greater than 1.5 centimeters. So let's look at these things. Conjunctival injection, see it right there? And here, and a little bit here, okay? Induration, very red, lips. They can crack. Okay, this is the same. The first child with the conjunctival injection. Look at the lips, what they call the strawberry tongue. Okay. There's the peeling of the fingers. Okay. Some more peeling. Now, strep can do this, but it usually doesn't go all the way like this and into the wrist. Okay. So, you suspect Kawasaki's. What is your next step? Pardon? There's no test. Biopsy. No. It's a clinical diagnosis. There is no test to diagnose Kawasaki's. Okay, so if you suspect Kawasaki's, your next step is not steroids, you'll kill them. Echo. Echocardiography. Okay? Pardon? I don't know that answer. I don't know that there is a predisposition. Okay? Your next step is an echo because there's a very high likelihood of having coronary artery vasculitis. Okay? And your treatment is immune globulin. And you can give aspirin. Aspirin helps with the fever. Aspirin helps with the very high platelet counts. Okay? So if you suspect Kawasaki's, you have to get an echo. There is no test that says, aha, Kawasaki's. It's a clinical diagnosis based on the criteria we just went over. But there's a very high incidence of vasculitis, particularly coronary artery vasculitis, so you echo them, and you need to give them intravenous immune globulin. Okay? Complications, coronary artery aneurysms, coronary artery thrombosis, MIs. They can have high drops of the gallbladder, which will cause some abdominal pain. They can have an aseptic meningitis, sterile pyuria. The thrombocytosis is uniform. It will have really high, and that's a later stage. But this is the big one right here. Okay? And if you do not, even though it's an itis, you don't treat with steroids. You treat with immune globulin. Okay? All right. Henoch-Schönlein purpura. A 5-year-old boy is seen with maculopapular lesions on the legs and buttocks. He complains of abdominal pain. He has recently recovered from a viral upper respiratory infection. CBC, coagulation studies and electrolytes are normal. Hematuria, microscopic hematuria is present on urine analysis. Preceding viral infection. Okay? And then you get these purpuric lesions. See them down here. They can occur anywhere. Classically, on the buttocks and legs, from the waist down. They can occur anywhere. Here's another one. Purpuric lesions, they're palpable. Okay? So it's an IgA-mediated vasculitis of the small vessels. Look for a past history of an upper respiratory or a viral infection. Boys are more common, and it's 4 to 8 years of age. And the skin lesions are the giveaway. You can do all kinds of tests. There is no test to diagnose HSP. You can have edema and arthritis. They can have GI symptoms, including a colicky abdominal pain, and you can get into susception with HSP. They can have blood in the stool. Renal manifestations can occur in up to half the patients, and they'll have hematuria, proteinuria. They can have some renal failure. CNS involvement can occur, usually seizures. There's no diagnostic test, but you have to rule out things, so you're going to get a CBC. You're going to get your BUN and creatinine and electrolytes. You're going to get coagulation studies, and they'll be normal. And the treatment is going to be supportive. Most patients, they'll get better, then there may be a relapse, and then they stay better. And if you have GI and CNS complications, you will use steroids. You have, I think in your papers, a nice table of the arthritis syndromes in pediatrics and what you find with each one. I think it's when we gave you the handouts the first or second day. And it's a nice table with lupus, JRA, rheumatic fever, Kawasaki's, things like that. Okay? It's in the batch that we gave you the second day, I believe. An 8-year-old boy is seen in the emergency department with vomiting and abdominal pain of 2 days' duration. His mother states he has been drinking a lot of fluids for the past month and reports weight loss during that time. Physical exam reveals a low-grade fever and a moderately dehydrated boy who appears acutely ill. He is somnolent but asks for water. This is typical. Respirations are rapid and deep. What kind of breathing is that? Kussmaul respirations. Rapid and deep. And lab reveals a metabolic acidosis and hyperglycemia. Okay? So diabetes mellitus, we're into a new chapter now. Diabetes mellitus results from a deficiency in insulin. Could be a defect in its action or a combination of both. But what happens is you have abnormal carbohydrate metabolism, also protein and fat metabolism because of that. The cells don't get any glucose, so they have to break down other energy sources. So they start breaking down fat, for instance. And when you break down fats, you get what? Ketone bodies as a breakdown of fat for your energy source. And that's why when this goes on enough, you will have diabetic ketoacidosis. We have type 1 and type 2. Type 1 is known as insulin-dependent diabetes. There's a severe lack of insulin. This is what you're going to see in children, type 1. Okay? There are starting to see in older obese children type 2, but for all intents and purposes in pediatrics, you're thinking type 1. What causes diabetes? Felt to be autoimmune. Sometimes you will have a preceding cold or something, and then the patient starts to get sick with the diabetes later. Okay? It's more common in persons with other autoimmune diseases, and there is an association with certain HLA antigens. It can run in families, and sometimes you may have a preceding viral infection. Most children, the initial presentation is DKA, diabetic ketoacidosis. So it's an acute presentation with polyuria, polydipsia, may or may not have polyphagia, and they will have weight loss. So up to 25% will have diabetic ketoacidosis, and they then will come in with vomiting, abdominal pain, moderate to severe dehydration, Kussmaul respirations. They may be lethargic or obtunded. Many of them will be asking for water or ice chips. They're thirsty because they're so dehydrated. Okay, so diabetic ketoacidosis occurs when your glucose is greater than 300 in the blood, and you will have ketonemia and acidosis. Usually your pH should be less than 7.3. This is the definition of DKA. Okay, it's blood glucose greater than 300, pH less than 7.3, ketonemia. They'll have glucosuria and ketonuria. Now, you can diagnose it in younger children without showing up in DKA. You'll get the history of the polyuria, polydipsia. You check, there's glucosuria, you get blood sugars, and they're high. The new criteria are going to be symptoms of diabetes, and you should have a random blood sugar of greater than 200 or a fasting blood sugar of greater than 126 or a 2-hour glucose tolerance of greater than 200. Okay? So hyperglycemia, glucosuria. Treatment consists of insulin, diet, and exercise. Okay? If you're in DKA, it's insulin and fluids. So you correct the dehydration, you correct the acidosis by giving insulin and fluids. Complications of diabetes include retinopathy, cataracts, nephropathy, neuropathy. Most complications do not occur in childhood, they occur in adults. The majority of children will then come back in with diabetic ketoacidosis, but they don't have those complications until they're much older because it's a more chronic disease. Okay? A 2-month-old patient appears to be having inadequate weight gain. His mother states he is constipated. On exam, he has decreased muscle tone, a large fontanelle, a large tongue, and an umbilical hernia. This is a classic hypothyroidism. Okay? Congenital hypothyroidism is because you have a deficiency of thyroid hormone. The very first day, we talked about screening tests, and this is one of the screening tests that you do, is for thyroid. So congenital hypothyroidism is about 1 in 4,000 births, so it's fairly common. Usually it's because of thyroid dysgenesis. Patients present just like on that in this question, right? They may have prolonged jaundice, poor feeding. They tend to be kind of floppy or somnolent. Look for a large tongue, constipation, umbilical hernia. They may have somewhat mottled skin. They may be constipated. Okay? They will be failure to thrive. They also will have developmental delay. And that's why you have to pick it up early. That's why we do the screening test. Because the earlier you pick it up, the treatment is just replaced with thyroid hormone. The earlier you pick it up, then you avoid all these problems, and particularly the developmental delay. Okay? The fontanelle is another key. A somewhat large fontanelle, particularly a large posterior fontanelle. The fontanelle in an infant, the anterior fontanelle will close by about 9 to 18 months of age. The posterior fontanelle may be closed at birth, but usually closes by 4 to 5 months of age. So if you have a large fontanelle, particularly a posterior fontanelle, and all these other things, you should be suspicious for congenital hypothyroidism. And you do a screening test. Newborn screening tests will pick up the majority of cases. You will see decreased T4 and elevated TSH. And you can also do a thyroid scan, but the first test is going to be your newborn screening test, and then if not, you get T4 and TSH. And the treatment is easy. You just replace thyroid hormone. The earlier, the better. Acquired hypothyroidism. Usually, thyroiditis is the most common cause of acquired hypothyroidism. There are some patients, like Down syndrome patients, Turner syndromes, and Klinefelter syndromes, they have a higher risk for autoimmune thyroid disease. Also remember irradiation and ingestion of iodides. The first sign of acquired hypothyroidism is growth deceleration. So remember when we talked yesterday, the first day, and we showed the growth curves, and we showed the person that was falling off the growth curve? That's the one you have to pay attention to. That's the one, he's going across the percentiles and starting to fall off. That's how they'll show. So growth deceleration. Patients can develop constipation, cold intolerance, and decreased energy. Usually schoolwork and grades don't suffer. Osseous maturation will be delayed. The first signs for lymphocytic thyroiditis will show up with growth retardation and a goiter. And again, you run the same thyroid studies to make your diagnosis. And you replace. Hyperthyroidism. A 12-year-old girl has a 6-month history of hyperactivity and declining school performance. Oh, a little bit different, eh? Appetite is increased, but she shows no weight gain. Physical exam reveals a slight tremor of the fingers, mild exophthalmos, and a neck mass. Okay, so too much thyroid hormone causes hyperthyroidism, and it's almost always a result of Graves' disease, which is diffuse toxic goiter. You can have neonatal hyperthyroidism. So that's another one. The mom has Graves' disease, and the patient is born, and you'll see these patients, they have a jacked up metabolism. They will have some exophthalmos, and they don't gain weight well. These are the ones, they're failure to thrive. They may have tachycardia, and you need to pick these up early and treat them. So that's a subset. That's congenital or neonatal hyperthyroidism. Symptoms develop over 6 to 12 months in hyperthyroidism. They can have emotional disturbances, motor hyperactivity, emotional lability, and look for their grades going down. They can have tremors. Sometimes you don't see the tremors so well. What you can do is put like a sheet of paper over their hands, and then you see the paper kind of vibrate as they're holding that paper, and you see the tremors from that. They eat, but they don't gain weight. It's not worms. Exophthalmos can occur, and they'll have sweating and flushing. These are all signs and symptoms. Tachycardia, palpitations. Thyroid storm is a severe presentation, and it can kill you. It's not common in children. But I do remember a neonatal one about a year ago that did die. Diagnostic tests. T4, the free T4, T3, and free T3 are elevated, but the TSH levels are low. So you have lots of hormones, of thyroid hormone circulating around. You don't need thyroid-stimulating hormone. Medical treatment consists of propylthiouracil or methimazole. Propranolol can reverse symptoms in severely toxic patients. And then surgery or radioablation is the ones who do not respond to medical management. A 1-month-old infant is seen with vomiting and severe dehydration. Physical exam reveals ambiguous genitalia. An exam shows, laboratory test shows hyponatremia. Okay? So is this a boy or a girl? How do you know? How do you know it's a boy? Could be a girl. Okay? Boy or girl? Don't know. Okay? Okay? And look at how hyperpigmented this is. That's very typical of congenital adrenal hyperplasia. Okay? This is adrenal hyperplasia. Look at the adrenals. They're huge, sitting on top of the kidneys. Okay? So ambiguous genitalia, the most common cause of ambiguous genitalia is congenital adrenal hyperplasia. The most common form of congenital adrenal hyperplasia is 21-hydroxylase deficiency. Okay? So congenital adrenal hyperplasia results from cortisol deficiency, which causes increased corticotropin secretion, and then your adrenals get bigger. Autosomal recessive. It's autosomal recessive. And again, 21 is the most common, but you also have 11 beta and 3 beta. and it depends on the enzyme deficiency how they present. With 21-hydroxylase deficiency, with salt losing, they will have virilization and ambiguous genitalia in the females. Patients can have vomiting. And so they come in, this 1-month-old, vomiting. Could it be pyloric stenosis? Sure. Now they show up with hyponatremia, though, sodium of 116. Maybe they have a seizure because the sodium is so low. Right? Non-salt-losing boys have premature sexual development, and the girls will have pseudohermaphroditism. All right, what test do you get? Hyponatremia, hypochloremia, hyperkalemia, and an elevated BUN are seen in the salt losers. Plasma renin is high and aldosterone is low. The 17-hydroxyprogesterone level is elevated in 21-hydroxylase deficiency. You have to get all these tests. Now, if you have ambiguous genitalia, what's the best test to determine the sex of this child? Is a karyotype. You can do a buccal smear, right, and look for bar bodies. But the best test will be a karyotype. You can get urinary 17-ketosteroids, going to be elevated. And prenatal diagnosis can be made by measuring hydroxyprogesterone and androstenedione in amniotic fluid. What's the treatment? Steroids. Okay, glucocorticoids will prevent androgen production and subsequent virilization. And when you're sick, you need increased doses of your steroids. Why? Because your body can't produce them, and you're under stress. So sometimes you have to jack up the doses, or else they come back in sick. All right, now we're going to go to hematology, probably do this chapter, break, okay? An 18-month-old child of Mediterranean origin presents to the physician for routine well child care. The mother states that the child is a picky eater and prefers milk to solids. In fact, the mother states that the patient who still drinks milk from a bottle, ooh, bad, right? 18-month-old, still on a bottle. Does he have any teeth left? Right? Consumes 64 ounces of cow's milk per day. The child appears pale. The hemoglobin and hematocrit were measured, and the hemoglobin is 6.5. The hematocrit is 20. Okay? And your MCV is low. So, what's your most likely diagnosis? Iron deficiency anemia. Why? Because of this excessive milk intake. Okay? And he's not intaking, he's not having iron from his diet, as far as he's not eating many solids. We could probably, what if I throw in that he's been drinking milk since he was like, whole milk since he was like 7 months old? Okay, so we talked about that during the nutrition chapters. So whole milk is only good for baby cows, anybody over a year of age. Okay? And in this age group, iron deficiency is probably due to poor intake of iron. Iron deficiency anemia is a microcytic hypochromic anemia commonly seen under 2 years of age. After that, children can pretty much go out and get their own food. They can open the refrigerator door and eat stuff, right? It's the most common hematologic disease of infancy and childhood. There are some risk factors. Low birth weight, for example. Inadequate dietary intake, particularly 9 to 24 months of age. And, not as common, blood loss. Now, blood loss can occur because of peptic ulcer disease. Blood loss can occur from a Meckel's diverticulum. We said painless bleeding, right, with Meckel's earlier. Polyps can bleed. Yesterday when we talked about parasites and we talked about hookworm infestation, if you have a big enough infestation, you can have anemia. And whole cow's milk during infancy puts you at very high risk for an iron deficiency anemia. And that's the most common cause is going to be inadequate iron intake, dietary. The patient will typically be on a diet of milk and not eat a whole lot of other things, just like this question said. Okay, that's a giveaway. Mild anemia usually presents no symptoms. It's when you get to more moderate to severe anemia that you start to see lethargy, anorexia, irritability, and easy fatigability. You can present in high output failure when a hemoglobin is less than 3. Why is that? Because the heart, you get tachycardia, and the heart can only go so high. Children already have higher heart rates than adults, and they can only crank up so high, and they start to fail. The patient can be pale, tachycardia, and you can hear a murmur because of the increased flow secondary to the anemia and the tachycardia. You can have spoon nails, and you may have splenomegaly on exam. Retic count is usually not high, okay? And the treatment is going to be iron supplementation. So you get a retic count now, and then you get a retic count later, and you see it just go way up. Your retic count can be actually a little bit higher than 1%, but it won't be high compared to the degree of the anemia. So you'd expect if this child was anemic, have a really high retic count. Well, you don't always see that. It may be high, but not as high in relationship to that anemia. A CBC should be obtained as your first test to see what your hemoglobin is. And you will also see the size of your red blood cells. So the first test you're going to get is a CBC. You can have thrombocytosis. And then you get serum iron levels and ferritin levels, and they're decreased. And your iron binding capacity and your free erythrocyte protoporphyrin will be increased. How do you treat these patients? You supplement with iron. That's all you need to do. And you will see an enormous increase in the retic count within about 72 hours. Okay? And your hemoglobin, you have a really good response by 3 to 4 weeks. Now, patients who tend to be very symptomatic, very anemic, you may need to transfuse them. And the transfusion needs to be done in small amounts. You don't want their hemoglobin to go from 4 to 11 overnight or in one transfusion, okay? Because the heart's not used to that. So you need to come up slowly. You bring it up a little bit and then finish bringing it up with the iron. So iron replacement is the way to go. And you will continue with iron replacement for 4 to 5 months after it's been at a normal range, the iron level, the hemoglobin. And you need to teach the parents to dietary counseling so that they will feed this child some form of iron. Okay? Complications can include learning problems, actually, from your anemia, and developmental problems. The differential includes lead poisoning, thalassemia, and anemia of chronic disease. A 2-year-old boy presents to the physician's office for an ear check. The child had an ear infection that was treated with trimethoprim sulfamethoxazole 3 weeks earlier. On physical exam, the patient is noted to be extremely pale. And you do a hemoglobin and hematocrit, and it's 7 and 22. So this patient has anemia And now we need to differentiate what kind of anemia it is. In this particular case, you're going to be suspicious for hemolytic anemia. Why? Because of the prior exposure to the sulfa. Hemolytic anemia is because you have decreased red blood cell survival. They're being destroyed. And there are two types. Premature destruction caused by intrinsic red blood cell abnormalities, such as spherocytosis, or enzyme defects, such as galactose 1-phosphate dehydrogenase deficiency, G6PD. Hereditary spherocytosis is the most common inherited hemolytic anemia. It's autosomal dominant, and you will see spherocytes on your peripheral smear. Okay? And since they're that different shape, they get chewed up going through the spleen and through the capillaries. G6PD, it's a variant of it's an enzyme problem, and that causes low enzyme activity, and you get hemolysis. Patients with spherocytosis, look for a history of the family of having like gallbladders removed or spleens removed or jaundice, a family history of it. Patients with spherocytosis may have splenomegaly on physical exam. Spherocytes will be seen in the peripheral blood, and you will have a negative Coombs, and the test that you do to diagnose hereditary spherocytosis after you see them on a peripheral smear is the osmotic fragility test. Okay? You can see gallstones in patients with hereditary spherocytosis. G6PD, think of blister cells on the peripheral smear, and you will have reticulocytosis. Your bone marrow is working overtime. And you can check for enzyme activity. How do you treat spherocytosis? Well, you can give them folate therapy if it's a mild spherocytosis. More severe spherocytosis, you eventually have to remove the spleen. But you try to wait as long as you can to remove the spleen. Afterwards, you obviously should think that these patients are at higher risk for pneumococcal disease. Once the spleen is out, anybody who's had their spleen removed, you know that they're at higher risk for this. Okay? So these patients will receive vaccinations. G6PD, in this particular case, this patient probably has G6PD deficiency. The sulfa probably triggered the hemolysis. And we talked about G6PD when we talked about the newborn with jaundice. So you need to avoid the sulfa drugs, the fava beans, the antimalarials, the mothballs. Okay? All right, let's show you something else. Let's show you a picture now. All right. I wasn't asking a question. They're very good. You're on top of things. Of course, that's the next thing we're going to talk about, so kind of easy to do that. A 6-month-old African-American infant presents to the pediatrician with painful, swollen hands and swollen feet. So sickle cell disease. You have valine is substituted for glutamic acid at the 6th position of the beta chain. One lousy amino acid screws everything up. It's amazing. Okay? So now you're going to have rigid crystals when the oxygen levels are low. That's what's going to, so you don't get a flexible cell. Usually in the newborn you won't find any manifestations. You wait, usually with sickle cell disease it takes about 2 months for things to start happening because you still have fetal hemoglobin. Okay? After the first month you're going to start seeing hemolytic anemia, and they can develop hand-foot syndrome or otherwise known as dactylitis. First of all, let's show you this. Here you have these bizarre-shaped, sickled cells, okay? And if you look right here, see that right there and there and there? Those are Howell-Jolly bodies that you'll see on the peripheral smear, okay? Dactylitis, or hand-foot, are the usual, as many times as the first presenting sign of sickle cell, and it's painful. These are painful crises. They can also have entrapment of those bizarre-looking cells in the spleen, and you have autoinfarction of the spleen with time. That means that even though the spleen is not taken out, it's not functioning anymore, and they're at higher risk for infections with encapsulated organisms such as strep pneumonia. Sometimes patients in males, they'll have priapism, which is a painful erection because those sickled cells get stuck in there, okay? They will have all these vaso-occlusive episodes that repeat over time. They can have what they call chest syndrome, where they get like pulmonary infarcts, or they get problems, it hurts to breathe, then they get hypoxic, it's painful to breathe, so they take shallow breaths, so they get hypoxic, so they have more sickling, and it's a vicious cycle, okay? So they will have a higher risk for infections. They can complain of chest pain, back pain, abdominal pain, and this is like a recurrent happening. Vaso-occlusive episodes can cause ischemic damage, bone infarcts, splenic infarcts, pulmonary infarcts, and stroke, and you can have splenic sequestration. The best test to diagnose sickle cell is electrophoresis, hemoglobin electrophoresis. Now you can see that they have, you can do a peripheral smear, you can see that they have an anemia from a CBC, but the best test is going to be a hemoglobin electrophoresis. Okay? They can develop gallstones because of the hemolysis. Patients should be immunized, particularly pneumococcal vaccines and H-flu vaccines. They need prophylaxis with penicillin. They need folic acid supplementation. You need to be very aggressive treating their with antibiotics. And painful episodes need to be treated with analgesics and proper hydration. Some patients need transfusions because the whole cycle starts when they get somewhat hypoxic. So you give them oxygen, you transfuse them up, transfuse up the hemoglobin, and they start to feel better. Some patients are on regular hypertransfusion protocols. Okay? Patients may require, sometimes they'll use hydroxyurea, and some patients end up with bone marrow transplantation. Complications, infections. Okay? Remember the pneumococcus, remember salmonella. And the leading cause of death is going to be infections. Okay, this is thalassemia. A 9-year-old has a greenish-brown complexion. They all pretty much look alike. A 9-year-old has a greenish-brown complexion, maxillary hyperplasia. That's what you see right there. Splenomegaly and gallstones. Hemoglobin is 5. MCV is 65. Thalassemia major, or Cooley's anemia, or homozygous B, results from an imbalance of the alpha and beta globin chains. You have too many alpha chains, and you have ineffective erythropoiesis, and you have hemolysis. Reduced oxygen carrying capacity, ineffective increase in iron absorption, and red marrow expansion are present. That's why we have this picture. That's why they have these typical faces. First of all, they have this discoloration under the eyes, and they have this maxillary hyperplasia. And you see it right here. See right there? And that's because this constant hemolysis causing the anemia stimulates the bone marrow. And normally your bone marrow up in your face is not a major source of red blood cells, but these patients are they're recruiting every bone they can, and so they will have this hyperplasia, and the bone marrow cavity expands, and that's why they look like this. So they can try to make red blood cells to keep up with the demand. They also can have, you don't see it here, but it looks like the hair on end or the hairbrush on the skull film, because again, there's expansion of the skull of from the bone marrow to help produce red blood cells, and that's why they look like this. Okay. The patients usually become symptomatic at about 6 months and up as they lose their fetal hemoglobin. They can be pale from the anemia, or more commonly they have this greenish-brown color to them. It's a jaundice from the hemolysis, but it's not your pure yellowness that you see in the babies. Facial deformities can occur from the bone marrow expansion. Splenomegaly is present. They can have heart failure, secondary to high output, not high urine output, but high output. So fix that. A complete blood count will usually have a hemoglobin of 2 to 6.5. And the smear will show hypochromia. And they develop hemosiderosis and this increased iron, right? So how do we treat hemosiderosis? Deferoxamine. On peripheral smear, hypochromia, microcytosis are found. Bizarre fragmented cells, the bilirubin, the indirect or unconjugated bilirubin is increased. And the diagnosis, electrophoresis. So just like sickle cell, the best test to make your diagnosis is going to be hemoglobin electrophoresis. And these patients need recurrent transfusions all the time. And they will need chelation because of the iron overload from getting all these transfusions, repeated transfusions. And you can use hematopoietic stem cell transplantation. Okay? So those are hemolytic anemias. Let's talk about just pure red blood cell anemia. A 2-week-old on routine physical exam is noted to have pallor. The birth history is uncomplicated. He's been doing well according to the mom. Diamond-Blackfan syndrome. So if you see a newborn or a neonate, 2-week-old, 3-week-old, and they're already anemic, you should be suspicious. They may be sometimes born with a low hemoglobin. Usually babies are born with hemoglobins around 17, 18, 19. Okay? These babies may be 9 or 10. And they're not yellow because it's just that they're not, this baby's not yellow because there's not hemolysis going on. This baby's just not producing red blood cells. That's why they're pale and not yellow. So that's important when you're reading the question. This baby's pale, not yellow. So you know he's not hemolyzing. He just has a low hemoglobin. Diamond-Blackfan is a congenital pure red blood cell anemia. It's probably genetic, and they will appear pale in the first few days, and they will be profoundly anemic by 2 to 6 months of age. They may have associated congenital anomalies, okay? Absent thumb, radius, things like that. Laboratory exam, CBC shows a macrocytic anemia, but they are anemic. Bone marrow aspirates show erythropoietin, but no bone marrow activity. So a bone marrow aspiration shows no bone marrow activity. Bone marrow failure, no red blood cells are being produced. These patients need to be transfused long-term. Steroids help. They are at high risk. They will end up having bone marrow transplantations. Okay? They're going to have iron overload because of the transfusions. Pancytopenia. So a CBC is very important in evaluating these patients because you find out anemia, you find out your hemoglobin, you find out your volumes, okay? Microcytic, macrocytic. In this particular case, this next patient, a 2-year-old presents to the physician with aplastic anemia. The patient has microcephaly, microphthalmia, absent radii, and thumbs. I take that back on Diamond Black fan. I was thinking of Fanconis. They're the ones with absent thumb and radius, so I take it back. Okay? In this case, you're going to do a CBC and all cell lines. Okay? So when you're evaluating a patient, you need to make sure what cell lines are working. And a CBC is helpful. If you have normal hemoglobin, you know that's being done. If you have normal white count and normal platelet count. Now, if you just have one of them is down, you know that that's a cell line that's either not being produced or that's the only cell line that's being affected. So you limit your problems to just 3 basic cell lines. In this particular case, when you get a CBC, it's a pancytopenia. So you will see that all 3 cell lines are affected. It's autosomal recessive, and there's complete bone marrow failure. So it's an aplastic anemia. You also have the congenital abnormalities. They can have microcephaly, microphthalmia, hearing loss, absent radius, and thumbs. So again, severe pancytopenia is seen. The bone marrow is hypocellular, and you can do cytogenetic analysis for your diagnosis, confirming your diagnosis. You're pretty sure of it when you get a CBC and a bone marrow. And you can make a prenatal diagnosis. Therapy includes transfusion, antibiotics, because obviously since they have no white cells, or they will be at increased risk for infections. They need androgenic steroids and eventually bone marrow transplantation. They are at higher risk for AML. Acquired aplastic anemia. So now you're going to be reading a history of something before. So the patient is doing fine, something happens, now they show up pale. So look for a preceding viral infection. Like, what did we talk about during viral infections, during the infectious disease chapter, as a cause of aplastic anemia? Fifth's disease, very good, parvovirus, Fifth's disease. So if they've had a prior viral infection, now they show up and they have an aplastic anemia. Okay? Also medications. Okay, so physical, like ionizing radiation, drugs such as chemotherapy, chloramphenicol, anticonvulsants, and infections such as parvovirus or mono, and half the patients have no prior history. The first sign is usually hemorrhage secondary to thrombocytopenia, although they may present with an anemia already. Lab studies will show decreased platelets, decreased red cells, decreased white cells, and very scanty bone marrow. So the diagnosis is confirmed with that. So first you get a CBC, you see all 3 cell lines are down, then you go to the bone marrow. If it's something environmental, remove them from the source. If they're bleeding, you transfuse, you treat the symptoms, treat infections. And some patients will come back. The bone marrow will come back, but for the patients that don't, you need a bone marrow transplantation. Most patients will die from infections or bleeding. Okay, the thrombocytopenias. So we talked about anemia, we talked about pancytopenia. Now we're just going to talk about thrombocytopenia, just the platelets. A 4-year-old child previously healthy presents with petechia, purpura, and excessive bleeding after falling from the bicycle. Okay? A more classic presentation of idiopathic thrombocytopenic purpura is the parents bring you a 3-year-old for a rash and bruising. And the rash is really the petechia, and easy bruising. And you get a history of a prior viral infection a couple of weeks ago. That's your typical ITP. So look for, they've recovered from a viral infection, and now they have bruising and petechia. And on physical exam, the child looks healthy except for the bruises and petechia. Particularly, they might have petechia where they wear their underwear or socks and stuff because of pressure points. and otherwise the child looks fine. So that's probably ITP. So you get a CBC, and you see that your hemoglobin is normal, your white count is normal, but your platelets are low. So the CBC is the first test you're going to do. Most of these patients do not proceed to have bone marrows. Sometimes they do. If you treat them with steroids, you should do a bone marrow, because you want to make sure that the patient doesn't have leukemia before you start them on steroids and mask anything. Okay? So ITP is the most common cause of thrombocytopenic purpura of childhood. There is no apparent cause for this platelet destruction. It is immune mediated. You develop antiplatelet antibodies to your own platelets. It's probably autoimmune. 70% will have a previous viral infection. Okay? Usually 2 to 6 years of age, and there's no difference in sexes. Okay. Bruising and petechial rash 1 to 4 weeks after a viral infection. They look great otherwise. Intracranial hemorrhage occurs in less than 1% of patients. The mortality rate is very low with ITP. They usually present with petechia, purpura, and maybe bleeding. Joint bleeding is very rare. This is that's hemophilia. Okay? And they look normal except for the skin. Okay? Platelet counts are low. That's the first thing you do is CBC and get a platelet count. Usually, they can have, the first sign is just that they have the hemorrhaging or the bruising or the petechia. The bone marrow, if it's done, will be normal or show increased megakaryocytes. Now, if they ask you, they tell you that this child comes in with, and you say you suspect ITP, the next test, best test, is a CBC. Don't go to the bone marrow item. The first test you're going to get is a CBC to see what your white count is, your hemoglobin, and your platelets. That's the best test if you suspect ITP. Okay? Not everybody gets a bone marrow. Treatment, most patients don't even need treatment. Okay? They recover on their own. Intravenous immune globulin does help, and steroids help. Usually you give IVIG because you get a big bump right away, and then that gets them through. Rarely do they, sometimes they do need to go on platelets, on steroids. Okay? If you're going to do this stuff, you definitely need to get a bone marrow aspirate. Other causes of thrombocytopenia, Wiskott-Aldrich. We already talked about that, right? So remember, they have low IgM, recurrent infections, it's X-linked, Mr. Text, all right? This is Kasabach-Merritt syndrome. There's a big hemangioma. That's cavernous hemangioma that traps the platelets, and that's a cause for the thrombocytopenia. Okay? Rare. But it will cause thrombocytopenia. Okay? And then we have another one called TAR, thrombocytopenia absent radius syndrome. Pretty much explains itself. Okay? This is a twofold. Let me see what I have here. Yeah. This is a twofold slide. This is a slide that shows a lot of petechia. Okay? So I kind of took this slide to show you what ITP looks like. Look at all those petechia. Okay? Because of a low platelet count. However, when we get to the next chapter, I can very well use this slide and tell you this is a child with leukemia. Because they can present like this because of thrombocytopenia. Okay? So if it's ITP, idiopathic thrombocytopenic purpura, the patient really looks fine other than petechia. So I put it on this side, but I can just as easily use it for the next chapter. All right, hemophilia. 3 types that we're going to think about, okay? Hemophilia A, factor VIII deficiency. Okay. Hemophilia B, factor IX deficiency, and von Willebrand's. Hemophilia A is the most common, followed by von Willebrand's, followed by hemophilia B. Okay? A newborn infant has prolonged bleeding after circumcision. There's no family history of bleeding disorders. Okay? So hemophilia A is X-linked, recessive. Blame who? Queen Victoria. She started the whole thing, right? Okay. It accounts for 80% of all hemophilias. And 1 in 5 to 1 in 10,000 males will be affected. There's usually a family history. Bleeding can be seen at any time. Typically, you do a circumcision, you get prolonged bleeding. Or you give an IM injection and they bleed. And certainly if you haven't done it if you haven't picked it up in the newborn or early on, then you'll start seeing when the baby starts to move around a little bit more. The hallmark of hemophilia A is spontaneous hemarthroses. Okay? So 90% of patients will have increased bleeding by age 1, and they'll have bruising with ambulation resulting in a hemarthrosis. And you may have visible bleeding or bleeding into the joint. So get a good history, a family history of bleeding, and here's how you're going to diagnose it. A prenatal evaluation with the family history makes you real suspicious. Prolonged bleeding after a circumcision makes you suspicious, but that could be a factor IX deficiency. So you don't know that it's factor VIII deficiency. So the way you're going to diagnose factor VIII deficiency is factor VIII activity levels. Okay. Toddlers with excessive bleeding from falls, prolonged PTT. The PTT is a nice screening test. Okay? That's a very nice screening test, but the actual diagnosis will be made with factor VIII levels. Okay, so there you have laboratory tests include factor VIII activity, normal von Willebrand factor, and the PTT is prolonged with normal platelet counts. And the PT and bleeding times are normal. So, factor VIII level. How do you treat these patients? You need to replace factor VIII. Now, factor VIII is short-lived, so it's not like they're going to be getting it daily. Factor VIII doesn't last very long, so you need to give it when they have bleeds to try to control the actual bleed at that time. So you only give it when they're bleeding, when they need it. DDAVP can help increase factor VIII levels in some patients. And you need to obviously be careful. You don't want these guys playing rugby, riding motorcycles or horses and things like that. You want to be careful that you don't do things that will hurt you or bruise you. You want to avoid like aspirin or anything that could cause bleeding. And it's very important to have physical therapy because when you have these bleeds into the joint, these joints get very deformed. They hurt and you don't use them as much, and so you need physical therapy. Okay? Follow-up or complications include developing inhibitors to clotting factors. And that's more common in hemophilia A than in the other two. Okay? Hemophilia B. A 2-year-old presents to the pediatrician and is noted to have excessive bruising during physical exam. The mother says that the child's skin is very sensitive to bruising. She also notes that the child has epistaxis. There is a family history of bleeding. Okay? Again, you can't tell the difference between one or the other unless you get levels. So in this case, when you're drawing levels, you're going to get factor VIII and factor IX and von Willebrand factors, and then they come back and you know which one it is. Factor IX, vitamin K dependent factor, but you cannot clinically distinguish one from the other. It is X-linked recessive also. And the exam is the same as hemophilia A. And the therapy includes replacement with factor IX. Okay, von Willebrand, this is an underproduction of von Willebrand factor or protein. And what does that stuff do? It causes platelet adhesion, platelet aggregation, platelet to platelet aggregation, and it's a carrier for factor VIII. So patients really don't have spontaneous bleeds into the joints like you do with the hemophilias. They may present with nosebleeds. Now remember, yesterday we said nosebleeds are usually trauma, nose picking, things like that, not von Willebrands. But they can present that way. It is autosomal dominant, so girls can get von Willebrands. Okay? They will present with nosebleeds, bleeding from the gums, menorrhagia, prolonged bleeding from cuts. But you will not really see bleeds into the joints. Again, you're not sure, so you're going to get all three, 8, 9, and von Willebrand factor, and that's the one that you're going to see will be decreased. And the treatment will be replacement with fresh frozen plasma or cryoprecipitate and you can use DDAVP also.